So, as David said, I spent some time in Mongolia and spent the better part of 2 years there. Some of that on a Fulbright, some on some other related funds, but the whole purpose of my work was to work with the public health system in order to improve service delivery in rural areas. And this is a picture. I'm showing a lot of pictures, very few words. This is a picture of what rural Mongolia looks like. This is the home of a community health worker who lives in a province called Bulgan, which is probably about 100 miles, 150 miles south of Russian Siberia. The reason that I went there was that Mongolia really presents a lot of very severe, extreme challenges to thinking about health services delivery and more broadly, thinking about community and population health. So I find that people generally know a little bit about Mongolia. Everybody knows a little bit about Mongolia, but very few people know a lot about Mongolia. So I'll give you a brief overview and then we'll get on with it. Mongolia is a very rural country, very sparsely populated. By size, it's as big as all of Western Europe. By population, it has less people than the state of Iowa. And most of those people live in a single city. So when you get out here, you have people that live in gers like this, are nomadic, move from 4 to 10 times per year to meet the needs of their grazing animals, camels, goats, sheep, horses, and on. And your nearest neighbor, if you live out there, can be 4, 5, 6 miles away. But you actually have some really interesting statistics and outcomes related to health. You have one of the strongest immunization programs in all of Asia, and everybody in these rural communities is visited by their provider, like this one pictured here, at least once a month. We talk about home-based visits. This is an example of it. This woman, her name is Naran Tsitig, a colleague that I worked with a couple years back. She has a catchment area that includes a population of 800 people. Not a lot, but that population is spread over an area. Y'all know about McAllen, Texas, right? 10 times the size of McAllen. If anybody's from Texas, that's the size of Houston. She goes by horse, she goes by motorcycle, but she sees all these people once per month. What makes this model of what's called Belchers, it's a Russian word, unique in the context of global health is they're paid, they're clinically trained, they're drawn from the communities, they're based in the communities, and they focus not only on curative care, but on prevention and wellness, one of the themes of the conference so far. So this is what home care looks like, a house call. House call isn't just about doing a house call, it's about the details. I think you can see a lot in terms of the body language, in terms of a way that this Feldsher on the right is interacting with a patient. I don't know, maybe we should get away from the word patient, an individual in our community. They are tied into the health system. They refer when necessary, but these places might be 40, 50 miles away from a home. So a lot of the care, a lot of the wellness focus happens out in those rural areas. This is a picture, it's like a Where's Waldo. The man in the red pants is a volleyball coach, beach volleyball coach. He's also a herder, and he's also a Feldsher. Wanted to show this because it shows how deeply integrated these folks are into their communities. Now, wasn't sure if I should show this quote because I think it sort of disproves my point. It says the relevance of the Feldsher to healthcare in the United States would appear to be limited. That was from the NIH. It was a 1972 report based on the Feldsher model in the Soviet Union at that time. What's interesting about this to me is two things. First of all, I would argue even at that point there's probably something to learn. Secondly, 40 years ago we were doing this, why aren't we doing this more now? Models change. One focus of my work was looking at the role of information and communication technology in supporting the work of these Feldshers. It's a pilot program, but people were using these PDAs. What's happened over the last couple of years is mobile phone networks have finally gotten out into rural areas in Mongolia, is that these Belchers and other healthcare providers are organically using these mobile phones for health while other elements of the health system lag behind. That sounds familiar at all to anybody? So, the only point I'm trying to make here is that there are very interesting models outside the US. This is my work in Mongolia. I thought it would be a good one to talk about in brief. We can talk about the details of it more outside if anybody's interested. The point of this talk isn't really about Mongolia or about Belchers or community health workers in Mongolia. It's that there's a lot of very innovative, creative approaches out there that health systems and NGOs and private providers are developing or have developed in response to very difficult circumstances. Mongolia, like I said, it's a very extreme place. Blue is where we are. Orange is where Mongolia is. And in green, you might recognize the pattern: Japan, Taiwan, UK, Switzerland, Germany. 5 countries that were recently part of a PBS special. Now, I think we should be looking at these countries, but there's a lot of other countries on that map. Of course, we sometimes look at Canada, we look at some other countries in Western Europe, but there are a lot of other countries out there. There's a lot of innovation happening. And what I'm proposing is simple. Let's look at those models and let's see what we can learn from them. It's only one single tool in an entire toolkit, and we're going to hear about the entire design process and the innovation process later. Tim Brown, Carl Rahn, Christy Zuber, Maggie Breslin are all going to talk about design, and they're going to talk about the entire process. What I'm proposing is, within that entire process, while we're focusing on domestic issues, we should take this, look at these models, and try to help us develop new solutions. Thank you.